Hi, Dr. Evelyn.
Hi there, good morning.
Good morning. Um, Eloka, sorry, I just want to know how to pronounce your name properly.
Yeah, Eloka.
Eloka. Okay,
Yeah.
thank
Starting
you
in 1 minute. Sorry.
for joining us today. Really appreciate your time. And well done, Dr. Evelyn. Amazing work you're doing.
No, amazing work that CAHN's doing. It's absolutely amazing. And that's what you've got to do. You've got to do stuff for us, by us. That's my hashtag. For us, by us. Honestly, nobody else is going to do it.
Mhm.
Oh, thank you. Thank you. Where in London are you based?
Mill Hill, Northwest London.
Oh, not West London. Okay. All right. I'm
I'm
in London
starting now.
actually.
Oh, okay.
Steph, we're starting in a few seconds, so you need to be off camera as well, please.
Oh, you want me to be off camera? Okay.
No, Stephanie, please.
Oh.
No, you, Dr. Evelyn. Good morning. This is Fabiola.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
Hello, hi, good morning, everyone. Welcome, welcome to another Health Hour talk held by CAHN. Well done for getting up early and joining in. My name is Dr. Eloka. I'm a GP trainee, and today we're going to be hosting a talk on sickle cell and the eye, what you need to know. We're joined today by the esteemed Dr. Evelyn Menzer, who is a highly experienced, knowledgeable woman who is a consultant ophthalmologist. And she's been a consultant for a very, very long time. So she's got a wealth of experience. As always, we encourage everyone to be inquisitive and join in via chat. Just pop in, let everyone know, let us all know where you're joining in from, what country you're joining from, and share experiences with sickle cell and the eye, and any questions as well. As always, after talk by Dr. Evelyn Menzer, we'll have a Q&A. So any questions that you have, pop it into the chat box, and I will be monitoring the chat box, and then we'll let Dr. Evelyn know about your questions. Thank you again for joining, and I'll hand it over to Dr. Evelyn.
Yes, hi, good morning, everybody. Thank you, CAHN, again for inviting me to speak on the topic of ophthalmology. It occurred to me that and all the times I've actually been asked to come and speak for this CAHN Health Hour, I don't really think I've actually explained who I am or what I am or anything like that. So I'm going to try and do that this morning. I'm just going to share my slides. Okay, so today I'm talking about sickle cell and the eye, what you need to know. My name's Evelyn Mensah. This is the Caribbean African Health Network. I noticed there were a few hashtags, so if you're on social media and you want to publicize the event, I think I put hashtag, I like a good hashtag, hashtag Health Hour. And if you can just kind of promote the event and put hashtag Sickle Eye, and it's the 28th of September today. Well, who am I? Everybody calls me doctor, actually, but I'm actually Miss. I'm a surgeon. And in England, anyway, particularly, if you are a surgeon, you go to medical school. Can you imagine? You go to medical school for 5 years, 6 years, and then when you become a surgeon, you lose your doctor title, and then you become Mr., Miss, or Mrs. And I am married, but I still use my maiden name. So my name's actually Miss Evelyn Mensah. Most people call me Evie. I've been called Evie since school days. And I am a consultant ophthalmic surgeon, which means I'm a surgeon who operates on people's eyes. I'm actually the clinical lead for ophthalmology at Central Middlesex Hospital at London Northwest, which is the trust where I work in Northwest London. Central Middlesex covers the borough of Brent. We serve the population of Brent. I'm the co-lead for ophthalmology for the Northwest London Acute Provider Collaborative. And also within my organization, which has between 8,000 and 9,000 people, I'm a workforce race equality expert. So I'm very much somebody who understands matters pertaining to race, health inequity, systemic racism. So a lot of my talks that I give will have that emphasis too. And I've also was just telling everybody that I'll be inaugurated as the president for the ophthalmology section of the Royal Society of Medicine, and I'll have my presidential address on the 10th of October. But that's another topic, a whole other topic in itself. So the overview for today is that I'm going to be talking about the eye, then I'm going to be talking about sickle cell, and I'm going to explain how sickle cell affects the front of the eye and the back of the eye. And then I'm going to finish off by talking a little bit about sickle inequity, and I will be explaining what I mean by that. So let's start off with the eye. So the sense that people rely on the most and would be really worried about losing is their eyes. All right. And everybody's got different eyes. Everybody's eyes are different. Okay. In the world of ophthalmology, which is the world that I live in, as small as the eye is, as small as that organ is, it's a massive subject. All right. We have got different subspecialists that specialize in different parts of the eye, and there are about 9 different subspecialties. Okay. My particular speciality is the back of the eye, the retina, and I do cataract surgery, which is at the front of the eye. So whilst I'm an ophthalmologist, I'm specialized in the retina. I do my commonest operation I do is cataract, but there are lots of different people that do lots of different things for the eye. And the world of ophthalmology, eye conditions, eye disease, it's a combination of attending the clinic, outpatients, and surgery. And as I was trying to allude to, there are lots of different surgical procedures that we do. There are lots of treatments that we do in the clinic, like laser and injections. And with the outpatients, there's lots of different subspecialist clinics. And it's one of the busiest outpatient specialities. If you go into the NHS, and if you're looking at busyness, ophthalmology is the busiest, much more busier than orthopedics and any other speciality. This is me doing cataract surgery. I love operating. I love teaching people how to operate. It's one of those specialities where you have to be ambidextrous. You're using both eyes to look down the microscope. You're using both hands to hold the instruments, and you're using both feet to control the machine and to actually control the microscope, the operating microscope that lets you operate on people's eyes. And we normally do this with just anesthetic drops. That's all, with the patient completely awake. It's a very satisfying operation, cataract surgery, which is the commonest operation that we do. I love training. Usually I'm training, and it's really satisfying to remove a cloudy lens and replace it with a plastic lens implant. And I'm clinical lead for about 75 different members of staff. And we are a multidisciplinary team, as well as the ophthalmologists, which are the eye doctors. We've got our resident doctors, we've got nurses, HCAs, optometrists, orthoptists, lots of things beginning with O. And honestly, it's like a big family, and I'm really privileged and lucky to work at Central Middlesex. So that's a little bit about me. So what I'm going to talk about with respect to sickle cell, I just want to talk a little bit about the history of the condition itself. All right. Sickle cell was described thousands of years ago, and it was named under a variety of different names that related to cultural, spiritual beliefs. So if you go back in time, and if you happen to be in Nigeria, the Igbo language, the word that they gave for sickle cell was Ogbanji, which means children who come and go. Because unfortunately, thousands and thousands of years ago, there was no treatment for this condition. But what they recognized was that children who had this condition were always unwell, and they felt that they were coming and going, because there would be alive, then there would be unalive. But they felt that even though it was an inherited condition, they felt that the children were reincarnated by some means of a malevolent spirit. Sickle cell itself is a global condition. It's a global condition that occurs worldwide. But sub-Saharan Africa is the region with the highest prevalence, the highest number of people suffering with sickle cell. West Africa particularly has got the highest or the largest population of people living with sickle cell. And outside of West Africa, the Caribbean has the highest incidence of sickle cell. But this is due to the transatlantic slave trade. That is why sickle cell is in the Caribbean, because Africans living in West Africa were extracted and taken over to the Caribbean during the transatlantic slave trade. So when you look at the research that's been done in sickle cell, some of the research has been done in sub-Saharan Africa, but the most important research, clinical trials with sickle cell affecting the eye were done in Jamaica. Now, this first so-called publication, and the reason why I've got publication in inverted commas, because as I said to you, sickle cell existed in Africa, West Africa, thousands of years ago. So for this publication, to be told to be the first in 1910 is a bit ludicrous, really, if you think about it. But in the global north, a Chicago physician in America apparently published the first medical paper about sickle cell. And the thing is about these publications, it's interesting, isn't it, that things that are written in medical journals are considered to be publications, and yet the narration, the verbal conversations, the folklore, the stories, the poems, the narrations that happen with medical conditions are negated, and these need to be written down, but they should not be dismissed. But anyway, I'm digressing a bit. Back in 1910, this Chicago physician published a first medical paper about a blood sample that had been taken from a 20-year-old medical student from Grenada who was badly anemic and was suffering with a lot of painful episodes. And within that blood sample, what this Chicago physician found were red blood cells, which were shaped like a sickle. A sickle is like a kind of like a knife sort of thing. And this is the publication: peculiar, elongated, and sickle-shaped red blood corpuscles. Corpuscles are red blood cells in a case of severe anemia. And he describes in the paper a chemical condition of the blood. Do you see how he's described them? an intelligent Negro of 20, let's gloss over that, from Grenada, the West Indies. So that's where they first so-called described it. So how common is sickle cell? Well, there are 4.4 million people who have sickle cell disease in the world. There are 43 million people who are living with sickle cell trait in the world. They are the carriers. It affects 1 in every 2,000 live births in England, and it is actually one of the most common genetic conditions affecting people in England. And sickle cell trait or disease actually has a protective effect against malaria in endemic regions, which is why it's so prevalent, the condition. If you want to learn more about sickle cell, the condition, I thoroughly recommend this sickle cell education series. Dr. Rosby Owadzi, this lovely doctor here, and he's here, is the CEO of this company that deals with medical education. And he, together with his colleagues, has developed this sickle cell series that is designed specifically for people who are sufferers of this condition and carers and anybody else. And you can log on to this website, www.sced.co.uk, to actually take advantage of the educational materials, because it's so important for people to be educated and to understand their condition. And even if you don't know anything about it and you're a healthcare professional, I thoroughly recommend it. So Rosby Awadsi is the CEO of this company called Get Medical, and he was supported by NHS England to set up this educational series. And I saw on LinkedIn last night how they went into it. I love jewelry. They went into a jewelry store and they basically did a whole educational series within this really cool jewelry store. How innovative is that? And they encourage people to have blood tests, and they encourage people, you know, to become blood donors, because unfortunately within our community, there are not many people who want to donate blood. I can understand that, but it really is a lifesaver for people who suffer with sickle cell. Now, sickle cell is a condition where there is a genetic mutation, all right? There is a change in the normal sequence within the DNA, which then means that in situations where there is not enough oxygen, the red blood cell, instead of being circular, like a biconcave disc, like a disc shape, then assumes this sickle appearance. Now, the problem with those blood cells that are sickled is that they are rigid and they are very stiff. So what that means is that they get stuck in blood vessels. And when they get stuck in the blood vessels, what that does, it causes a significant amount of pain. The pain is unbearable, all right? Because what you're doing, if the blood cells are blocking off the blood vessels, it's blocking off the oxygen blood supply to certain organs, and it can be incredibly painful. And it also causes a lot of an anemia in sufferers. Yes, so this is just a schematic diagram to show a blood vessel that's branched into two, and you can see the normal biconcave disc-shaped red blood cells with a few white cells, and you can see the sickle cells here, and you can see that they would be quite rigid and they block the blood flow. As I was telling you, sickle cell trait, that's when you're a carrier. So your genotype is hemoglobin A, S, so your trait, and it provides survival advantage against malaria. But sickle cell, the condition itself, you can either be homozygous, which means that you can have 2 of the genes. So you're homozygous SS, which is the most commonest type, and it's the most severe subtype of sickle cell. Or you can be heterozygous, which means you're hemoglobin S with a different other hemoglobinopathy. So some people can be hemoglobin SC, some people can be hemoglobin S beta thalassemia. There are lots and lots of different genotypes for sickle cell. Okay, so now what I'm going to talk about, so I've talked about the I, talked a little bit about me, who I am. as an ophthalmologist. I'm not an optician, ophthalmologist, eye doctor. Talked about sickle cell. Now, what I'm going to do is I'm going to talk about how sickle cell affects the eye, and it does affect the front of the eye and it affects the back of the eye. But I'm just going to just do it together because there's not many, it doesn't really, there's not much to say about the front of the eye. So this is a diagram of the eye. The front of the eye would be from the lens. This is the lens behind the iris, the colored part of the eye. All right. So any conditions at the front of the eye are out here, and the back of the eye is everything like the retina, the macula, everything at the back of the eye. So the macula, they made a bit of a mistake on this thing, is an area here with the fovea at the center. Now I have a dedicated sickle clinic, okay? And in the how many years I've been the clinic, I've been doing it dedicated since 2017. I've only ever seen one person who's come with blood at the front of the eye. This is a condition called a hyphema, where there's just spontaneous bleeding at the front of the eye. So it's not very common, but it can happen. You can, on the white part of the eye, you can get these little wiggly blood vessels, tortuous blood vessels. Doesn't affect the sight. That's nothing to worry about. Sometimes the white part of the eye can be a little bit yellow. Now, this yellow here is just a yellow dye that we use commonly in our eye clinics. So it's not like yellow like this, but the white part of the eye can sometimes look a little bit yellow, and that's because of the red blood cells being broken down and increased levels of something called bilirubin from the breaking down of the red blood cells. You can also get cataract, but it's not the commonest cause of cataract, but it can happen. So now we're going to move to the back of the eye. Now, when we're talking about the back of the eye, we talk about sickle cell retinopathy, all right? Things that affect the retina. And it can be divided into non-proliferative sickle cell retinopathy that does not affect the sight. It's non-sight threatening. Or proliferative sickle retinopathy, which can be sight threatening, not all levels of it. And I'll go through that in a minute. And the thing that you can get with both of them is something called sickle maculopathy. And I'll talk about that a little bit later. So let's start off talking about the conditions that are non-proliferative sickle retinopathy. And just to gently remind you, this does not affect the sight. It is non-sight threatening. So the sort of things that can happen is that this is a picture here of the back of the eye. All right, that's the nerve. That dark area there is the macula. These are all the blood vessels that are branching out, okay? What can sometimes happen in people with sickle cell at the back of the eye, and you would never know it unless somebody looked at the back of the eye, is that you can get these things called salmon patches. Now, salmon patches is the name that they gave years ago, decades ago, all right? And what it is bleeding on the surface of the retina. This bleeding does not affect the sight, all right? But like blood goes through color changes. So as the blood is hemolyzing, sort of like regressing, it goes from red, then it goes to like an orangey yellow, and then a yellow, and then it might disappear. And that's where the name salmon patch comes from, okay? So these are the salmon patches in the edge of the retina. When the blood has completely absorbed, what it does is it leaves behind these yellow crystals. Can you see those yellow crystals? Let me just put my magnifying. Yeah, you see all these little yellow crystals? That again is nothing to worry about, okay? This picture is a series of pictures showing what happens with the salmon patch, what I just described. So there you go. You've got the red blood on the surface, then it goes yellow, like a salmon patch, then it leaves behind yellow crystals. That's the hemosiderin, the yellow crystals. Again, nothing to worry about. So don't worry if you're a sickle cell sufferer and somebody has all these words in your letter, this does not affect your sight. When that blood is completely resolved, what happens is that you get pigment put in the retina. It's described as a black sunburst, all right? And this is a response to the previous bleeding. So in this picture here, you can see that little patch of black. It's just a lot of pigment. Again, in the edge of the retina, not affecting your seeing part of the retina, doesn't affect the sight. All right, this is non-proliferative. It is non-sight threatening. This is another photograph, somebody's left eye, that's their nerve, that's the macula. You see how far away it is. This is this part here, right? This part in the middle here, that's what you use to see. This is far away, doesn't affect your sight. Okay, so we've talked about how it affects the front of the eye, sickle. We've talked about how it affects the back of the eye, but non-proliferative changes. Now I'm talking about proliferative sickle retinopathy, which can be potentially sight-threatening, but not for everybody. All right. Proliferative means things that grow. That's what proliferation actually means. Now, do you know that the classification of proliferative sickle cell retinopathy was done all like in 1971? All right, more than 50 years ago, and there's been no updating of that classification. There's been updating of the classification for how diabetes affects the eyes, right? Diabetes is a condition that affects the eyes and the back of the eye, the retina, like sickle cell. And there's been loads of different classifications, loads of research done on that. But when it comes to sickle cell, there's been one classification from 1971, okay? It's not enough. But anyway, here we are. This person called Goldberg classified proliferative sickle cell retinopathy into 5 different stages: stage 1, stage 2, 3, 4, and 5. And we are going to go through what those different stages look like at the back of the eye in the next slide. Now, proliferative sickle retinopathy stage 1, and I need to move that little bar. If you present, you know what I'm talking about, it's getting in my way. Stage 1 is peripheral arteriolar occlusion. So what is it that I actually mean by that? Let me just show you. You see these blood vessels here, all right? In this particular patient that we took the picture on, we said that there was no sickle retinopathy. If you then go 6 months later, can you see how you've got this blood vessel here, and then it becomes white? It's red, and then it becomes white. This one here, look, it was there, then it's disappeared and it's become white. Blood vessels are supposed to have red blood going through them, okay? But what happens is that the blood vessels, they branch and branch and branch, and as they get narrower and narrower and narrower, the sickle blood cells block off and they make them have these little white appearance. This is called peripheral arteriolar occlusion. It just means blocked off blood vessels, all right, here. That is a very early stage of proliferative sickle retinopathy, but again, this does not affect the sight. So all that would mean is that if you are coming to an eye clinic, instead of being seen once a year for people who've got no sickle retinopathy, you might be seen once every 6 months. You'd be seen a little bit sooner just to make sure you're not progressing, all right? So this is stage 1, blocking off of the blood vessels, okay? Stage 2 is when you get the blocking, all right, and it's the artery that gets blocked. And what happens is that artery that gets blocked, it wants a supply. So what does it go and do? It joins up with a vein, all right? And that's what this is showing. This is called vascular remodeling, and AV, arterial, artery, joining with a vein, and anastomosing, joining up together because it's been blocked off. And so that's what, this is a dye test. This is the color photograph, all right, here. And this is the dye test, and it's showing how an artery is joining with the vein in this arch thing. And you see all these wiggly vessels? That's what happens at the edge, okay? And the other thing, in this dye test, which is called a fluorescein angiogram, which we do a lot in ophthalmology, even though you can't see it very well on the color here on the left, we can see that all of these blood vessels, can you see how there's no blood vessels there? There's no blood vessels. They're supposed to be there because they've got blocked off at the edge, all right? So that is why it is very important to monitor, because what we don't want is for abnormal vessels to grow and bleed. That's what we're monitoring for. Okay, so some people who suffer with sickle cell and they think, oh, when I go there, they're not doing anything. It's not that we're not doing anything. What we're doing is that we're monitoring to make sure you don't get the abnormal blood vessels, which can then bleed. So that's what AV, or arteriovenous joining up anastomosis, means. Now, the next stage is stage 3. This is when you get the, and I have to say it like this, abnormal blood vessels that begin to grow. Because what happens is that your retina, it needs oxygen. Where do you get the oxygen from? You get oxygen from the blood, all right? Blood, oxygen in the blood, and it nourishes. Oxygen nourishes the whole of our body. We are alive because we've got oxygen in our blood vessels that's providing nutrients to every part of our body. Now, in sickle cell, when blood vessels get blocked off in the body, it manifests up as pain. But in the retina, there's no pain receptors when the vessels get blocked off. But what happens is that the retina says, oh my gosh, I haven't got enough oxygen. So it then starts to release a growth factor. And what that growth factor does is it stimulates the growth of abnormal blood vessels. All right. So you see how you've got that's your nerve. This is your macula where you see. All right. This one, vein, artery, these are all normal branching blood vessels. A little bit wiggly because when you're anemic, your blood vessels are a little bit tortuous. All right. They're a bit wiggly. But then can you see how you get to here? All right. And there's like a sea fan. It's got a narrow base and a frilly frond like a fan. These are the sea fans. You see this one here down at the bottom. You see that's the normal blood vessel. And then these are sea fans. Now, the problem with the sea fans is that they are rudimentary blood vessels. Their walls are not very tight. It's like building a wall with no cement. All right. You know that if you built a wall and there was cement between the bricks, that wall would be very, very strong. But these new vessels, sea fans, these vessels that grow, the walls are not strong. They've not got the cement between the walls, and their walls are very fragile, which means that they can bleed very easily. Yeah. So this is stage 3. These are the sea fans. Somebody like this, again, we would monitor them regularly. We wouldn't necessarily, well, actually, nobody really knows when we should do laser treatment because I'll tell you a bit about that in a minute. But somebody like this, if they're flat, if they're not bleeding, but they've got these little sea fanny things, we would want to monitor that. And we would tell our patient that if you notice floating spots, it could be that the sea fan has bled. If the sea fan is bleeding, you must go to the eye clinic, all right? Because they then will need to give you some laser treatment to prevent any further bleeding, all right? It's not right to have bleeding inside the eye, okay? So this is stage 3 sea fans. We investigate as ophthalmologists, as eye doctors, we investigate the sea fans with this dye test here on the right, this black and white photograph. So what's happened is with the fluorescein angiogram, the dye, it's like a contrast media dye. It's injected in a vein in the arm, and then we take a series of photographs at the back of the eye. So you can see in this diagram here, you see now, this is a CFAN that has bled on the surface. This is not like the salmon patch, all right? This is sight-threatening, yeah? This needs treatment. So this is the CFAN, it's bled, and we can see the CFAN configuration. Can you see it? And can you see how it's grown in the area where it's dark here? There's no blood vessels. That's why it's grown. There's a growth factor that stimulated its growth. And as it stimulated its growth, it's caused it to bleed on the surface. So ideally, you need to apply laser around that CFAN. It's almost like, you know, you're like blocking it off. You're starving it. So it then shrivels and it scars and it becomes white. You want it to become white because when it's white, it's got no blood in it. And if it's white, that means it's less likely to bleed. Okay, so this is a CFAN that's bled on the surface. At this stage, it should have laser. But do you know, in the UK, treating this condition is not taught properly. And there are eye units in the UK where they will say that if there is bleeding, just leave it, it's going to get better. But I am telling you, I have a theory that the blood inside the eye is toxic. So that should not be taught, all right? I'll be telling you a little bit how we're going to change that narrative very soon, all right? People who have CFANs that bleed and have floaters, they should not be ignored. They need to be managed properly, okay? So anyway, now, this is somebody who had the CFANs, but their body caused them to scar up, all right? So they had the CFANs, they didn't have any laser treatment, yeah? And they then just scarred up like this, yeah? They've gone white. They've shriveled up like this one here and this one here. There's a little bit of red around it, okay? So that is fine. When they're like this, it's fine. But I can tell in this eye here, there must have been some bleeding because you see this little yellowy floaty thing. I think that at some point, this person had bleeding inside the eye. Ideally, what should have happened is that they should have had laser to surround it to stop the bleeding so that it didn't go from being on the surface to being inside the eye, okay? All right, so this is all stage 3, peripheral retinal neovascularization. Neovascularization means new blood vessels. The new blood vessels do not have strong walls like bricks with cement between them. They are very weak, they are very fragile, and they bleed. Not like normal blood vessels that have got the cement between and they're very strong, okay? All right, now, stage 4 is vitreous hemorrhage. What is vitreous hemorrhage? Vitreous hemorrhage is blood inside the eyeball. Now, can you imagine how scary that must be, right? 1 minute, you're seeing, everything's fine. The next minute, blood is inside your eye and you cannot see. That's scary, right? So that's why I think it is outrageous that we should be taught as ophthalmologists that if people were suffering with sickle cell and they have these abnormal blood vessels at the back of the eye, yeah, if they bleed, doesn't matter, it's going to clear up. It's not the point. That is not the point. The point is that we should be treated before you get to this stage. Why should anybody have to experience that? It's not right, okay? So ideally, what we want to do is we want to treat before they get to that stage. The blood does clear up quickly, but sometimes it doesn't. And then the person would then need to have an operation to remove the blood from inside the eye, okay? And as I said, I feel that blood is toxic when it bleeds inside the eye. And this is just another view of the person that had the bleeding inside the eye. Scary, scary. Stage 5 if you had a bleed inside the eye and you had lots of C-fans and it was not treated, what would happen is that you could get the scarring and it could crunch up the retina and pull the retina off, you know, a bit like pulling wallpaper off the wall. Yeah, this is a retinal detachment. You do not want your retina being coming off. All right, that is a massive operation. Not me, by the way. I don't do surgical retina. I do medical retina. So I do laser treatment, injections, things like that. But my surgical, I would then have to get my surgical retinal colleague to then do an operation to put the retina back on. Now, luckily for this particular person, I don't have a picture of a full retinal detachment, but what I'm going to show you is what the laser looks like. So this person, you see all these dark marks? These are the laser marks. You see this is that black sunburst, but there was a C-fan here. You see this white thing? That C-fan had bled, right? It's scarred, but can you see how there's like this V-shaped gap? That's a tear in the retina. So what happens with the retinal detachment is it starts off with a little tear, fluid goes in and it peels it off, you know, a bit like peeling wallpaper off the wall. So they've had laser around that tear to prevent a retinal detachment. But you can see all manifestations of all the previous stages of retinopathy, you know, the blocked up blood vessels. The reason why that C-fan grew there is because there were no blood vessels. There were blood vessels that were blocked off. They were all white, grew the C-fan, bled, had the laser treatment, okay? So this person is fine, all right? Now, so we've talked about how sickle affects the front of the eye. We've talked about how sickle affects the back of the eye with the retinopathy. Now I'm going to talk about how sickle affects the macula. The macula is the most important part of your retina. So you see this picture of this eye, all right? I don't know whether people are allowed to speak, but is this a right eye or a left eye? Does anybody want to tell me? Is this a right or a left eye?
Right eye.
Yay! Gold star. This is the right eye. Okay. This is the nerve. This is the macula here. All right. The nerve is always towards the nose. The macula is always towards the ear. So this is, as you're looking at the person, this is the right eye. Now, as vast as the retina is, and this picture doesn't take in all of, this is only, this camera is only 160 degrees. It doesn't take up the whole of the retina, but the part of your retina that you use to see things in fine, clear detail is this tiny area here in the center. Is tinier than a pinhead. It's the center of your macula called the fovea. But this whole area here is your macula. That is the most important part of your eye. The rest of your retina is, you use it for your peripheral vision. So whilst I might see my hands moving here at the side, as I'm looking at the screen, everything is in sharp focus because I'm looking using my macula. I can see my hand moving. That is my peripheral vision, but I don't read on the side. You see what I mean? It's your outside vision. So you need your macula to see your loved ones' faces. You need your macula to read those letters that come through the door, whatever. You need your macula to watch your favorite TV program, to drive. It's very, very important. It's very important. It's only 4% of the total area of the retina. It gives you clear, sharp vision, and it's what's responsible for your color vision. Most of your color photoreceptors, which are called cones, are in the macula. And this is what we investigate the macula using something called an OCT scan, where you put your chin on a machine, this light, blue light comes in your eye, and it gives you a cross-sectional impression of your macula, almost like looking at your macula under a microscope, right? With all the different layers, and your macula dips down in the center like a valley. It's very geographical. That's normal. The front of the eyes here, the macula is there. And this little video just shows you what scanning through the macula there. It goes, dips down like a valley. And this is called OCT scan, optical coherence tomography. We use this in the eye clinic to assess your macula. So we'll do photographs like you've seen but we'll do an OCT scan to give us the detail of what's happening in the macula. Now, sickle maculopathy can take various forms. You can get sickle maculopathy causing ischemia. Ischemia means blocking off of the fine blood vessels around the macula, not in the outside part of the retina, but around the macula. And what that does is it does two things. So this is the OCT scan here. Now you can see with this person's right eye, the macular tissue is of this thickness here, right? But on the side, can you see how it's thin? Yeah, it's thin and it's created this blue area. Blue is like thin, like bottom of the deep blue sea. It should be green and orange, right? Grass level. But the macula is thin on that side because the blood vessels at some point got blocked off. All right. So this person who's hemoglobin SS homozygous for sickle cell, they've actually got 20/20 vision. They've gone all the way down to the bottom of the chart. The reason they've gone back down to the bottom of the chart is because they've still preserved their fovea, the center. So they've got good vision. So that's one type of sickle maculopathy. This is one where it's called foveal splaying. Unfortunately, it's different to this one, right? Where it's just the side. This one, it's involving the fovea here. And because of that, they don't get to go all the way down to the bottom of the chart, okay? So there is different types of blocking off of blood vessels around the macula. The other thing that can happen in the macula is that you can get fibrosis. Fibrosis is like thickened tissue, fibrous tissue on the surface of the macula. And I'm telling you, this happens as a consequence of a vitreous hemorrhage, bleeding inside the eye, which is why I say patients who've got those abnormal vessels, the CAHNs, they should not be allowed to bleed inside the eye, because even though the blood might clear, all right, and the CAHNs may scar up, that bleeding inside the eye, I am convinced, causes these membranous bands, all right? So what am I talking about? I'm talking about things like this. This picture doesn't look like those previous pictures, does it? All right, because there's this white sheet of fibrotic tissue on the surface of the macula that's distorting the vision. Yeah. So when you look at the OCT scan, you see how it's lifting up here? That could lift off your whole macula, and then you're not going to be able to see very well. Okay. So that's not very good, is it? Yeah. You see this one? You see how there's all this sheet, luckily actually for this particular person. And you can see that doesn't look like the pictures that I showed you, does it? It doesn't look like that deep. It's not dipping down like a valley. I know you guys aren't eye experts, but I think you understand what I'm talking about. It's not that shape like dip down like a valley, and that's because of previous bleeding. And the consequence is that this person, they've got good vision in their right eye. It's about 20/20. They've got healthy macula. This eye, it was allowed to bleed. They ended up getting a macular hole. They had to have surgery, and their vision is only halfway down the chart as a consequence of that. So this happened in another unit. So when this patient came to me and I could see that they had a CAHN in this right eye, quickly I lasered that CAHN to reduce the risk of them actually having the same thing happening in that eye. Now, as I told you, sickle cell comes from West Africa, all right? And in the UK, in England, we have some people who manage patients with sickle cell, but the experience is in West Africa because they see more people, all right? So that is why the way we manage sickle cell, and I've been doing it ever since I've run my sickle clinic at Central Middlesex Hospital, I do exactly what they do in the Lions International Eye Centre, Kolibu Teaching Hospital in Ghana. All right. This is my friend, Kwesi Amasa Arthur. He is an ophthalmologist. He is a vitreoretinal surgeon. So he does medical retina like I do, but he also does surgical retina. So, Mr. Kwesi Amasa Arthur, ever since I set up my clinic, I would have little meetings with Kwesi, with my trainees and my colleagues, and Kwesi and his team in Ghana. Even before the pandemic, we were using like FaceTime and everything, and we would discuss cases and how we should treat them. So we do exactly what they do there. And Kwesi and I wrote a paper about the past, present, and future management of sickle cell retinopathy within an African context. And we published this paper in 2018, describing the challenges that there are. But because people in, I will say, the global north, UK, Europe, America, don't really know how to manage sickle properly, together with Kwesi and other people, we've set up something called the Sickle Cell Retinopathy Network. It's a global network, all right? It comprises multidisciplinary teams from countries where they've got people that suffer with sickle cell. So we call it the SCR net, all right? And our vision statement is that we want to reduce the prevalence of sight-threatening complications in people who suffer with sickle cell, all right? We want to highlight the importance of conducting research to reduce those complications, because there's not enough research, all right, into the condition to know what to do. So we want to address that at a global level and impact policy. So these are the founding members of the SCR.net. That's me in the middle. That's my colleague Rabia. This is Lizette. She is from Jamaica, Professor Lizette Moat. There is Kwesi there. That's a Kwesi from Ghana. That's Dr. Adetunji Adenekon. He is from Nigeria. This is Professor Winfried Omwaku. He's here in the UK in Nottingham. This is Mohammed Sharif Hussaini. He is a doctor in Ghana, a resident doctor. Aziz Sophia. She is a resident doctor in Ghana. This is Nena Osuju. She is a hematologist, all right? We're all ophthalmologists. Nena she is a hematologist. She also happens to be the CEO of North Middlesex, one of very few Black women who are CEOs of NHS organizations. She's amazing. And this is Professor Shobha Siva Prasad. She's based at Moorfields Eye Hospital. So we are the founding members of the SCR.net. I wrote about our network for the NHS Race and Health Observatory, telling them that what we wanted to do. This was last October. And I want to finish off talking a little bit about sickle inequity. But before I talk about inequity, I have to explain the difference between equality and equity. Equality is everybody having the same thing. All right. So if you imagine there's a fence, there's a baseball game taking place, you see everybody's getting the same. So you see this tall man with the blue shirt on, right? He can actually already see over the fence, but he's got the same as everybody else, so then he gets more of a boost up, yeah? This guy with the red top, he couldn't see, and he's still staying the same. But this short guy with the purple T-shirt, you give him the same, he still hasn't seen that baseball game, all right? So this is why I do not talk about equality. I never talk about equality. What I talk about is equity. What equity is distributing resources according to need, right? So that means this guy, if you've got more, you do not need more. This guy, yeah, you need something, but this short guy with the purple top, who's now really happy, his hands are in the air, he can see the baseball game. He's been given this guy's thing box, right? He's got 2 boxes, so he can see over the center. That is the difference between equality and equity. Equality is sameness. Equity is fairness. And you cannot talk about equality until you ensure there is equity. All right? And that's why I'm always picking up anybody who keeps on going about equality, this, equality, that. It's got nothing to do with equality. Let's get equity, then we can talk about equality. Now, inequality is uneven distribution of resources, but inequity is unfair and avoidable inequalities. That's not inevitable or natural, and it is the product of human behavior. So so I told you that sickle cell is a genetic condition, and it's one of the commonest genetic conditions in England. Cystic fibrosis, all right, is also a genetic condition. It's not as common as sickle cell, but it's almost the same, but not as much. But when you look at research and distribution of money, resources, these are the bars, these are the different funders, the NIHR, the UKRI, the Wellcome, all right? These are the funders for research. And this was a paper that was published by Mozambique. It was a blog published in May this year from Imperial Sickle Cell Comparative Research to Inform Policy Project. And what they've said is that of the three big funders, right? Guess who gets the most? Cystic fibrosis here in yellow, here, and here. Guess who gets the least? Sickle cell here, here, and here. All right? Now, when you look at the difference between sickle cell and cystic fibrosis, you've got a patient population of 11,000 for cystic fibrosis. Sickle cell, you've got more, 17,500. Births, 1 in 2,500, 2,500, 1 in 2,000. But NICE, the National Institute for Health and Clinical Excellence, has only approved 2 treatments. In fact, it's not even 2 now. It's gone down. There's another one that's dropped off. 512 treatments for cystic fibrosis. That's not right. Is that right? Yeah? So, and the only difference between the two is that cystic fibrosis predominantly affects white people and sickle cell predominantly affects Black people, Black African, Black Caribbean. Yes, it is in South Asia too, because of the thalassemia link. However, it's predominantly Black people. And that is the reason, for me, right, it's the very definition of systemic racism. All right, it's the unfair disadvantage for one group of people, unfair advantage for another group of people based on a social construct, which is race, which is the color of one's skin. And as I was just telling you, when I did this slide back in June, this one's now dropped off. So there's hardly anything, okay? And we all know about the No One's Listening publication from the Sickle Cell Society, where they said that there was a lack of awareness amongst professionals about sickle cell, the condition, and the experience of people who suffer with sickle cell in accident and emergency departments, where people have got such bad negative attitudes and they do not believe people, you know, when they are saying that they're in pain and I think they're drug addicts or something. It's outrageous. This needs to change. So I'm not a general doctor. I'm an ophthalmologist. And so that's why I have to do what I can from the eye point of view. And that is why I keep on talking about, I gave this talk, I was in Zimbabwe last month, and I gave this talk from the global south to the global north, empowering ophthalmologists in diabetic and sickle cell retinopathy. And I was in the place which I thought was called Victoria Falls, yeah, in Zimbabwe, but it's actually Mosi Oyatunya, yeah, because David Livingstone, all right, in 1755, thinks he discovered Victoria Falls. How ludicrous. The people in that country, the indigenous people, had already given a name to this one of these 7th, 8th wonders of the world, the falls. They called it Mosi Oyatunya. All right. What that means, it means the smoke that thunders. Yes. And I'm very much now for decolonizing healthcare and guidelines. And what do I mean by that? What I mean by that is that there's a colonial prejudice that dictates that everything that happens in the global north, Europe, UK, North America, only research from the global north is relevant and it should feed down to the global south. But when we're talking about decolonizing healthcare, what I'm talking about is shifting that paradigm. So we're changing the narrative. So it's research from the global south going to the global north. And that is what I want the Sickle Cell Retinopathy Network to do. I want information from my colleagues in the global south, in sub-Saharan Africa, in the Caribbean, who manage people with sickle in their eyes. I want us, our network, to shift that paradigm of knowledge. So we are telling the whole world globally how to manage the condition properly. So watch this space. And that is the end of my talk. Are there any questions?
Thank you.
I need to stop sharing. Hang on a minute. Let me just stop. How do I stop sharing again? Have I stopped sharing?
Thank you.
Good.
Yes, you have. Thank you.
Sorry,
Thank you,
everybody.
Evelyn.
You shouldn't get me started talking on these sorts of things, all right? Because I'll just go on and on and on. And I haven't got any time.
No, it's things that we really needed to hear, and like the explanation about differences between equality and equity was like really important. Thank you so much. It was such a great talk. We've got quite a few questions actually, so we'll just get started. Um, there's sort of Cassandra's asked basically that she's noticed that a lot of African and Caribbean elders experience glaucoma and cataracts. Is this a result of type 2 diabetes? Or are these eye issues more closely related to the impact
No,
of
they're
sickle
completely
cell?
different. Glaucoma is a completely different condition. Glaucoma is high pressure in the eye. And remember, I told you that we are all subspecialized. So my specialty is the retina. Glaucoma is to do with pressure in the eye. So I work with 2 glaucoma specialists. All right. It's high pressure in the eye that damages the nerve at the back of the eye. And that's another level of inequity. Why is it that Black people, Black African, Black Caribbean in this country, the glaucoma, by the time it's discovered, they're 4 times more likely to suffer with glaucoma compared with South Asian and white counterparts? Why is that? All right. There needs to be more research into the reasons behind this, and there should probably be screening or detection for glaucoma much earlier. So no, it's got nothing to do with sickle. It's a completely different condition. Cataracts is an aging condition of the eye. Everybody, as you get older, you're going to get cataracts, a bit like your hair going grey. There are some things that speed it up a little bit. Sometimes people say diabetes. I don't like saying it too much. It's not, I don't like saying it's a cause per se. Cataract is really more an aging change.
Okay, thank you very much. Maybe this is a question for the future. Someone's asked if we could do a future session on alpha and beta thalassemia.
Right, so remember, I told you I'm an ophthalmologist.
Yeah.
Eye doctor. Eyes. That's all I know.
So it's different.
Body. If there's conditions related to the eyes, yes. But what I'll say is that alpha and beta thalassemia doesn't really affect the eyes. Sometimes with people who have blood transfusion, they can get pigment deposits in the retina. So they may be screened. That is the only thing. I don't have a clinic that I have some thalassemia patients in my clinic, and that's only because they want to make sure that there's no pigment deposits from the iron from the blood transfusion. So you'll need to get a doctor, a hematologist, to talk about alpha and beta thalassemia.
Yeah.
But
So
not an
if there's any
ophthalmologist, not
hematologists
me. Yeah.
any hematologists that are interested, please hit us up. There is a question from Bisola called sickle cell is a devastating condition that affects beyond the person with lived experience. Prevention at every stage is essential. I agree. So in view of the high prevalence and well-identified genetic problems, how is screening of the population most affected? And who else wants to know? So I think it's a question about
It's probably a question
how
about
do
screening.
people
Get screened. So everybody gets screened. So there's one of the screening programs. Checking for sickle cell is one of the 9 conditions that's checked in babies when they're born. Okay, so this is the issue I have. All right, there are 9 different. It's a genetic condition. It's genetic, right? So there's that screening that needs to be done, and this is the issue that I have because sickle cell, along with cystic fibrosis, they are both genetic conditions that are screened in newborn babies. Every newborn child in England has screening for sickle and cystic fibrosis. And I don't know whether anybody is familiar with the Generation trial, the Generation study that started March this year. It's going to finish March next year, where they're going to screen 200 genetic conditions, all right, in newborn babies. But they're not, it's going to be offered, but maybe people will not necessarily take it off, and especially from our community, because there is a lot of distrust with research, and that's because of previous systemic racism, all right, and medical unethical practices. That's why people might not want to participate. But my thing is that you're doing this generation trial. We've already been screening for like, I don't know, a decade or more for sickle and for cystic, and there is that inequity. So how is bringing 198 other genetic conditions in going to help? Do you know what I mean? We're already doing it. We need to deal with the inequity that is already there at the moment, the inequity with research, the inequity with finding, effective treatments to manage the condition. That's what I would like, these drug companies and, people like UKRI, Wellcome, NIHR, I'd like them to focus more on what's happening now, because for me, the generation study is not going to make, I don't think it's going to make any difference. It might be for some other genetic conditions, but for people who suffer with sickle cell, I don't see how it's going to help.
Yeah. Thank you for that. So yeah, Bisola, so everyone at birth in this country gets screened. That's what you're saying for
Yes, they do.
sickle cell?
Newborns,
So
yeah.
every newborn. Okay. Okay, thank you. There is a question from Fiona. Sorry if I've really butchered that name, Fiona. But she says she attends Manchester Eye Hospital. She's regularly monitored for hemorrhages because she had a hemorrhage in her eye in 2019. So she's regularly monitored for that. She's asking how she can increase oxygen in her body to eliminate or reduce bleeds.
So there's probably evidence to suggest that your systemic management of sickle cell itself impacts what's going on in your eyes. Yeah, there's possible evidence. It's not been formally published, but there is evidence. So I think by engaging with your hematologist, making sure that you attend your appointments, making sure that you actually understand, go on that educational, please, I would encourage everybody to access that educational series that Rosby et al. Have put on, that's freely available to everybody, to educate themselves a little bit more about what they can do. So if you go on that website, you should be able to do that.
Thank you for that, and thank you for that for giving us that information about the resources. It's very important that we have access to all this as well. So
absolutely, it's so important.
Bisola has another question. Bisola has another question. She says, you mentioned that if you see floaters with a history of sickle cell, you should go to the eye clinic, which indicates urgency for the reversal of worsening of the situation. Is this an open door policy for the situation without a need for a referral from primary care?
So I think that what you need to do is that if you're already under the eye clinic, you contact them. It's not like necessarily urgent that you have to go within 24 hours. But I just don't think it's something like if you've been given a 6-month appointment or a year appointment, I don't think you should wait that long. I think you should always just get it checked. There are other reasons for floaters, which is just degeneration of the jelly in the eyes, floaters. But I think if you suffer with sickle cell, any genotype, if you've got floaters, I think you should just go and get it checked. Just say, look, I suffer with sickle cell. I'm told that you can get bleeds at the back of your eye. I have got floaters. Please, can I see an ophthalmologist? And I think if you go to any urgent care unit, they should be able to send you to the nearest hospital eye service.
Okay. Yeah. Thank you.
So rather than bothering your GP, because the GP can do it if you want to, but GPs are just so busy. I would just go to my local A&E. I say I've suffered with sickle cell. I've got floaters. Any urgent care. Can I be referred to the eye clinic? Or you can contact the GP, do an e-consult something, and just say, look, I suffer with sickle cell, I've got floaters, or even your hematologist, tell them, and they can do the referral that way. But there are lots of different ways to get referred in. It doesn't have to be now, like right at that point in time. Yeah, quite soon.
Thank you for that. Thank you, Bisola. I hope that helps you.
Yes, I can see the next question. It's talking about retinitis pigmentosa. No, it's not. It's not associated with sickle cell. Retinitis pigmentosa is a completely different condition.
Yeah. And there was a good question before that as well that Molly from YouTube asked about whether basically people when they come back from the homelands, they're turned away from being able to give blood. She's asking how we can overcome such disparities due to the rules.
They're turned away. This is not my this is not my specialist area. And this whole thing about, giving, there's just so much work that needs to be done. Don't you think?
Mm.
How
Yeah,
don't you
I
think
agree
with
completely.
our, not, I mean, honestly, seriously, there's so much that needs, there is so much, many assumptions, all right? Slightly
Mm.
anti-Black tropes, personally, that I feel that discourage people. So then why would they want to? You know?
Mm.
So that's why things like
Especially
Rosby's
people
doing.
who go home regularly.
Yes, I know, but if they want to, and that's why things like what Rosby's doing, like the young generation, is just so inspiring. Honestly, you've got to look at that thing that they did on the LinkedIn thing, Rosby, when they went to the jewelry shop. RB is the name of, I can't remember the name of the jewelry shop. I just saw it last night. I was like, oh my God, this is so cool. I wish I'd been there. And they were just basically just doing blood tests on people, different settings, different environments. And what that does is it encourages that level of innovation. It encourages our community to want to contribute and to help. It's not like necessarily the traditional way where they feel like they're othered or anything like that. They feel like that they've got something to contribute. They feel that, they can help, and they're not made to feel as if, other ways. It's not nice. I know what she's
Mm.
saying.
Mm. No, it's awful. Yeah, I agree.
Yeah.
But yeah, you're right. Like, if we give everyone more information, we can come up with our own ways, more innovative ways to overcome this. Um, there's a question that's asked, is there a way to raise awareness amongst GP practices and immigrants, as some patients were not screened as babies in their home countries before coming to the UK?
Good
From
question.
Anne on YouTube.
Yeah, that's a very good question. I just think that I think NHS England probably just needs to do more with that educational piece amongst all healthcare practitioners. I'm not sure that all
Mm.
healthcare practitioners are aware, and I think that different groups are doing their own thing in terms of raising awareness. I can't speak much more on that, I'm afraid.
Mm. No, thank you. But yeah, I agree as well. But I do think there is a lot more education coming out now and a lot more awareness. So I
There
think
is a little
in
bit
time,
more. We just have to keep on going.
yeah. Yeah. Janet asks, oh, I don't understand this question. Does this doctor have her own practice? Oh, do you have your own practice about
Me,
problems?
let me
Yeah.
tell you something. You're talking about me, private, me, no.
Yeah.
Can you not
Oh,
see the sort
okay.
of person? Can you not see the sort of person I am? Me, private. Listen, I was gifted a private practice by my mentor, and I lasted 6 years. So no, I don't do private practice. It's not for
Okay.
me. I'm NHS.
Um, yeah, good, good. So hopefully that answers the question, Janet. I think she said she's got problems with that with her eyes.
Yes, she needs to go to a
I think,
local eye hospital. Yeah.
yeah. Yeah. Um, oh, good question from Maya. Would you be able to pop in any links to any useful links into the chat? About the RB jewelry course thing the video about the RB jewelry thing would be a good one to put in there, and links to the sickle cell website as well would be good.
Yeah, I'll just try and find the Sickle education series. I'll do that quickly while you're just asking me about the next question, which I don't know what it is.
The next one is, which I think you touched on as well near the end, is how can we get our home countries to be leading the research on what
Very good
affects our
question.
people?
Very good question. You just start it. That's why I set up the Sickle Retinopathy Network. We're not waiting around for anybody. Okay.
Mm.
My mantra for this year is buy us for us, or for us by us, for us with a for us by us, because
Boo boo.
because there's just not, it's just I think people just have to just do their own thing, not do their own thing, but do it collectively.
Yeah. Without being held back because, oh,
Yes,
there's not enough research in this area, things like that,
exactly.
just to kind of be trailed. Yeah.
Yes, exactly.
Um, One question which isn't about sickle cell, but it's about cataracts. Iyabo asks, I wear glasses to read, but she's finding it difficult. I've been told, I think the cataract's not yet mature enough for the operation. Is there anything I can do to help myself?
There's nothing you can do to help yourself from getting older, my dear. That would be the elixir of life. Everyone's going to get cataracts as they get older. Okay, but glasses for reading, that's called presbyopia. That means that your lens can't change its shape easily. To be able to see in the distance and to near, your lens changes its shape for focusing for distance, and it gets fatter to focus for near. But as you get older, some people do need to have reading glasses. There's nothing you can do about it. And what people will do is that they'll hold the book further and further away. And you know what? You just need to just put on a pair of reading glasses, and you can hold it at the normal distance and you can see. All right. This is because the ligaments around the lens are stiff. They can't move much. So it's an aging thing. You can't do anything about it. It's called presbyopia.
Yeah.
Yeah.
Okay, and I think one last question, which is, I guess, a good way to summarize what's kind of we talked about earlier, is does sickle cell anemia affect you differently from anemia, from Debbie?
Well, there's lots of different types of anemias. There's thalassemia. There's
Yeah, so sickle cell is a
cell.
type of,
It's a
yeah.
type of anemia, but it manifests differently. But what's more profound about this particular anemia is the pain, is the painful crises, and the impact on practically almost every organ in the body. And that's why it's a condition that really needs to be managed very well, effectively. You know, how well have people well hydrated, well nourished, good levels of oxygen, and it's working together with your hematologist to be able to get that that balance right.
Okay, that was again. I'd just like to thank you so much for that talk. It was very informative. There's lots and lots of people excited in the chat about how they've learned a lot and they're really happy with your work. So hopefully we'll see you again at some point. And yeah, thank you very much. I'd just like to thank everyone else for listening, and I'd hand it over to Stephanie for to do any announcements and talks. Thank you.
Thanks for having me.
Thank you, Evie, and thank you, Eloka, for that wonderful presentation. It's really informative, and thank you, everyone, for joining us. So I'll put on my slides. Should be up. Let me know if you can see my slides now. Can everyone see my slides?
Yeah, we can. Once you make it full screen,
Okay.
to go.
Thank you very much again, Evie. That's really informative. I've learned more than enough from even just listening to you. It feels like going to medical school myself. We can actually become doctors by just coming to Health Hour. And thank you so much for that information about sickle cell and your eye. So next Saturday, we have another health.
Stephanie, could you make it full screen, please? Thank you.
Great. Okay. I don't know if you can see it now. Scroll. Is it better now?
No, if you go to the bottom right-hand side of your screen, by the minus sign, there's a little presentation thing. No, keep going down. Yeah, on the right-hand side, yeah, that one. Yeah, that one there. If you click that, it should make it full screen.
Is it better now?
No.
No. Yeah, that's what I thought. Okay, stop sharing and share again. Sam, will you be able to share your screen with me?
Bear with me 1 second, please.
Is it full or half still?
It's still half, but I'll share it from my side.
Okay. Right. Thank you very much, Sam. And sorry for the technical issues from my end. So next week on Saturday, on the 5th of October, at the same time, we're going to have the same health hour. It's going to be facilitated by Dr. Kamara, who is going to talk about mpox spread symptoms and prevention. And next slide. Yeah, thank you. And the next we'll talk about we have Healthy Hearts, which happens every Tuesday. The next one is going to be on the 1st of October at 6:30 p.m. to 8 p.m. And we're going to have our physical instructor, Orlando Grant, who is going to also lead us on physical activity. And the topic will be taking care of your health and well-being starts with maintaining a healthy diet and lifestyle. And if you can join us on the same day, on the 1st of October, that would be really nice. Next slide, please. And we're going to have a Black History Month Gala, which is a celebration of Black excellence. And join us for a night of elegance and purpose at CAHN on the 7th of October. 7th Black History Month on the 12th of October at Several a garment 3-course meal. And then you'll be able to meet people, network, have opportunity to also talk about the work you do. It's going to be a night of elegance. The tickets are selling really, really fast, and we encourage you to spread the word with your network. And it's in Manchester, but people are traveling from across the country to come for this gala, and you don't want to miss it. We want to also meet you. If you're a fan and a supporter of CAHN, this is an opportunity for you to come and celebrate with us, share with your network, and see how we can also celebrate with you as well. The QR code you can scan to buy your ticket. And as I keep saying, it's going really fast, and the location is at Hilton, Manchester, and it's also a prestigious place. And we all want to be there. We don't want to miss out. It's a Black tie event, and we should all come and celebrate the Black History Month. Next slide, please. And be part of the Greater Manchester event directory. If you scan the QR code on the screen, you'll be able to share all of the events happening for Black History Month, and CAHN will also be able to share it for you and share the details with us, and we'll add it to our Greater Manchester Black History Month event directory. We are doing the same for London as well. So if you have an event going on in London, just scan the QR code and also share with us, and we'll be able to publicize that on our event directory and also help you promote your event for Black History Month. We are here to support you and also promote what you're doing. In as much as you're supporting us, we also want to support you as well. Next slide, please. Yes, you can have an impact on health research that our community need most. So they join the DCYPHR from the NHR Bioresources. So research is done with us, not without us. So if you want to be part of it, you can also scan the QR code on the screen and be part of the research for DCYPR. Next slide, please. Yes, and can also have the Golden Hub, which is the health and well-being Caribbean and African culture well-being hub in Golden Monastery. It's a very beautiful place, and you can also be part of it. It's always happening first and third Saturday of the month. It's a Golden Sacred Heart Family Hub, and you can also come to the hub on these 10 days and also participate in it. What we do at the hub is dedicated to providing holistic perinatal infant mental health support for Black women and families across Greater Manchester. So we hope to see you there. You can also share this information with your colleagues and your network. And you can also scan the QR code to also book a slot to be part of the Golden Hub on the first and third Saturdays of every month. Next slide, please. Diabetes peer-to-peer support group can also have the diabetes peer-to-peer support group, which is led by amazing June. And diabetes support for people who are Black, Caribbean, and African living in North Manchester is open to adult with diabetes or pre-diabetes and their carers. So if you're in Manchester, you have a family or a friend who is suffering from diabetes, you can also call June for more information on this. And June's details are on the screen. And you can also book a playthrough or refer someone by giving them this number on your screen or giving them June's email address. And June is always a champion of diabetes, and she's more than happy to help if you call her. Next slide, please. And thank you all for joining us today. We hope to see you all next week. And please invite your network, invite your friends. Look at how informative this session is. You don't want to miss out. So please, please, all our friends, our network, the Black community need all of this information, and to be very good for us to invite them. And how do we invite them? Just share the link with them and they'll be able to join. You can also watch it on YouTube, also watch on LinkedIn, and also join us from our social media platforms as well. Thank you, and we hope to see you next week, same time, same day. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.